Hey everyone, this is Joanne. Welcome to my YouTube channel. Today we begin the audiobook on Harrison's Internal Medicine, the 21st edition. Let us begin with Cardinal Manifestations and Presentation of Diseases, so pain, pathophysiology and management. The province of medicine is to preserve and restore health and to relieve suffering. Understanding pain is essential to both of these goals because pain is universally understood as a signal of disease. It is the most common symptom that brings a patient to a physician's attention. The function of the pain sensory system is to protect the body and maintain homeostasis. It does this by detecting, localizing, and identifying potential or actual tissue damaging processes. Because different diseases produce characteristic patterns of tissue damage, the quality, time course, and location of a patient's pain lend important diagnostic clues. It is the physician's responsibility to assess each patient promptly for any remediable cause underlying the pain and to provide rapid and effective pain relief whenever possible. The pain sensory system. Pain is an unpleasant sensation localized to a part of the body. It is often described in terms of a penetrating or tissue-destructive process. Examples: stabbing, burning, twisting, tearing, squeezing, and or of bodily or emotional reaction. Example: terrifying, nauseating, sickening. Furthermore, any pain of moderate or higher intensity is accompanied by anxiety and the urge to escape or terminate the feeling. These properties illustrate the duality of pain. It is both sensation and emotion. When it is acute, pain is characteristically associated with behavioral arousal and a stress response consisting of increased blood pressure, heart rate, pupil diameter, and plasma cortisol levels. In addition, local muscle contraction, example limb flexion, abdominal wall rigidity is often present. Peripheral mechanisms. The primary afferent nociceptor. A peripheral nerve consists of the axons of three different types of neurons: primary sensory afferents, motor neurons, and sympathetic postganglionic neurons. The cell bodies of primary sensory afferents are located in the dorsal root ganglia within the vertebral foramina. The primary afferent axon has two branches. One projects centrally into the spinal cord, and the other projects peripherally to innervate tissues. Primary afferents are classified by their diameter, degree of myelination, and conduction velocity. The largest diameter afferent fibers, A beta, respond maximally to light touch and or moving stimuli. They are present primarily in the nerves that innervate the skin. In normal individuals, the activity of these fibers does not produce pain. There are two other classes of primary afferent nerve fibers: the small diameter myelinated A delta and the unmyelinated C axons. These fibers are present in nerves to the skin and to deep somatic and visceral structures. Some tissues, such as the cornea, are innervated only by A delta and C fiber afferents. Most A delta and C fiber afferents respond maximally to intense, painful stimuli and produce the subjective experience of pain when they are activated. This defines them as primary afferent nociceptors, pain receptors. The ability to detect painful stimuli is completely abolished when conduction in A delta and C fiber axons is blocked. Individual primary afferent nociceptors can respond to several different types of noccistimuli. For example, most nociceptors respond to heat, intense cold, intense mechanical distortion such as pinch, changes in pH, particularly in acidic environment, and application of chemical irritants including adenosine triphosphate ATP, serotonin, bradykinin BK, and histamine. The transient receptor potential cation channel subfamily V member 1, TRPV1, also known as vanilloid receptor, mediates perception of some noxious stimuli, especially heat sensations, by nociceptive neurons. It is activated by heat, acidic pH, endogenous mediators, and capsaicin, a component of hot chili peppers. Sensitization. When intense, repeated, or prolonged stimuli are applied to damaged or inflamed tissues, the threshold for activating primary afferent nociceptors is lowered, and the frequency of firing is higher for all stimulus intensities. Inflammatory mediators such as BK, nerve growth factor, some prostaglandins, and leukotrienes contribute to this process, which is called sensitization. Sensitization occurs at the level of the peripheral nerve terminal, peripheral sensitization, as well as at the level of dorsal horn of the spinal cord, central sensitization. Peripheral sensitization occurs in damaged or inflamed tissues when inflammatory mediators activate intracellular signal transduction in nociceptors, prompting an increase in the production, transport, and membrane insertion of chemically gated and voltage-gated ion channels. These changes increase the excitability of nociceptive terminals and lower their threshold for activation by mechanical, thermal, and chemical stimuli. Central sensitization occurs when activity generated by nociceptors during inflammation enhances the excitability of nerve cells in the dorsal horn of the spinal cord. Following injury and resultant sensitization, normally innocuous stimuli can produce pain, termed allodynia. Sensitization is a clinically important process that contributes to tenderness, soreness, and hyperalgesia, which is increased pain intensity in response to the same noxious stimuli. Example, pinprick causes severe pain. A striking example of sensitization is sunburned skin, in which severe pain can be produced by a gentle slap or a warm shower. Sensitization is of particular importance for pain and tenderness in deep tissues. Viscera are normally relatively insensitive to noxious mechanical and thermal stimuli, although hollow viscera do generate significant discomfort when distended. In contrast, when affected by a disease process with an inflammatory component, deep structures such as joints or hollow viscera characteristically become exquisitely sensitive to mechanical stimulation. A large proportion of A delta and C fiber afferents innervating viscera are completely insensitive in normal, non-injured, non-inflamed tissue. That is, they cannot be activated by known mechanical or thermal stimuli and are not spontaneously active. However, in the presence of inflammatory mediators, these afferents become sensitive to mechanical stimuli. Such afferents have been termed silent nociceptors, and their characteristic properties may explain how, under pathologic conditions, the relatively insensitive deep structures can become the source of severe and debilitating pain and tenderness. Low pH, PGs, leukotrienes, and other inflammatory mediators such as bradykinin play a significant role in sensitization. Nociceptor-induced inflammation. Primary afferent nociceptors are not simply passive messengers of threats to tissue injury, but also play an active role in tissue protection through a neuroeffector function. Most nociceptors contain polypeptide mediators, including substance P, calcitonin gene-related peptide, and cholecystokinin that are released from their peripheral terminals when they are activated. Substance P is an 11 amino acid peptide that is released in peripheral tissues from primary afferent nociceptors and has multiple biologic activities. It is a potent vasodilator, causes mast cell degranulation, is a chemoattractant for leukocytes, and increases the production and release of inflammatory mediators. Interestingly, depletion of substance P from joints reduces the severity of experimental arthritis. Central mechanisms. The spinal cord and referred pain. The axons of primary afferent nociceptors enter the spinal cord via the dorsal root. They terminate in the dorsal horn of the spinal gray matter. The terminals of the primary afferent axons contact spinal neurons that transmit the pain signal to brain sites involved in pain perception. When primary afferents are activated by noxious stimuli, they release neurotransmitters from their terminals that excite the spinal cord neurons. The major neurotransmitter released is glutamate, which rapidly excites the second-order dorsal horn neurons. Primary afferent nociceptor terminals also release substance P and CGRP, which produce a slower and long-lasting excitation of the dorsal horn neurons. The axon of each primary afferent contacts many spinal neurons, and each spinal neuron receives convergent inputs from many primary afferents. The convergence of sensory inputs to a single spinal pain transmission neuron is of great importance because it underlies the phenomenon of referred pain. All spinal neurons that receive input from the viscera and deep musculoskeletal structures also receive input from the skin. The convergence patterns are determined by the spinal segment of the dorsal root ganglion that supplies the afferent innervation of a structure. For example, the afferents that supply the central diaphragm are derived from the third and fourth cervical dorsal root ganglia. Primary afferents with cell bodies in these same ganglia supply the skin of the shoulder and lower neck. Thus, sensory inputs from both the shoulder skin and the central diaphragm converge on pain transmission neurons in third and fourth cervical spinal segments. Because of this convergence and the fact that spinal neurons are most often activated by inputs from the skin, activity evoked in spinal neurons by input from deep structures is often mislocalized by the patient to a bodily location that roughly corresponds with the region of skin innervated by the same spinal segment. Thus, inflammation near the central diaphragm is often reported as shoulder discomfort. This spatial displacement of pain sensation from the site of injury that produces it is known as referred pain. Ascending pathways for pain. A majority of spinal neurons contacted by primary afferent nociceptors send their axons to contralateral thalamus. These axons form the contralateral spinothalamic tract, which lies in the anterolateral white matter of the spinal cord, the lateral edge of the medulla, and the lateral pons and midbrain. The spinothalamic pathway is crucial for pain sensation in humans. Interruption of this pathway produces permanent deficits in pain and temperature discrimination. Spinothalamic tract axons ascend to several regions of the thalamus. There is tremendous divergence of the pain signal from these thalamic sites to several distinct areas of the cerebral cortex to subserve different aspects of the pain experience. One of the thalamic projections is to the somatosensory cortex. This projection mediates the sensory discriminative aspects of pain, that is, its location, intensity, and quality. Other thalamic neurons project to the cortical regions that are linked to emotional responses, such as cingulate and insular cortex. These pathways to the frontal cortex subserve the affective or unpleasant emotional dimension of pain. This affective dimension of pain produces suffering and exerts potent control of behavior. Because of this dimension, fear is a constant companion of pain. As a consequence, injury or surgical lesions to the area of frontal cortex activated by painful stimuli can diminish the emotional impact of pain, while largely preserving the individual's ability to recognize noxious stimulus as painful. Figure 13.3. The convergence projection hypothesis of referred pain. Pain modulation. The pain produced by injuries of similar magnitude is remarkably variable in different situations and in different individuals. For example, athletes have been known to sustain serious fractures with only minor pain, and Beecher's classic World War II survey revealed that many soldiers in battle were unbothered by injuries that would have produced agonizing pain in civilian patients. Furthermore, even the suggestion that a treatment will relieve pain can have a significant analgesic effect, the placebo effect. On the other hand, many patients find even minor injuries, such as venipuncture, frightening and unbearable. And the expectation of pain can induce pain even without a noxious stimuli. The suggestion that pain will worsen following administration of an inert substance can increase its perceived intensity, the nocebo effect. The powerful effect of expectation and other psychological variables on the perceived intensity of pain is explained by brain circuits that modulate the activity of the pain transmission pathways. One of these circuits is links to the hypothalamus, midbrain, and medulla, and it selectively controls the spinal pain transmission neurons through a descending pathway. Human brain imaging studies have implicated this pain-modulating circuit in the pain-relieving effect of attention, suggestion, and opioid analgesic medications. Furthermore, each of the component structures of the pathway contain opioid receptors and is sensitive to the direct application of opioid drugs. In animals, lesions of this descending modulatory system reduce the analgesic effect of systemically administered opioids such as morphine. Along with the opioid receptor, the component nuclei of this pain-modulating circuit contain endogenous opioid peptides such as the enkephalins and beta-endorphin. The most reliable way to activate this endogenous opioid-mediated modulating system is by suggestion of pain relief or by intense emotion directed away from the pain-causing injury, example during severe threat or an athletic competition. In fact, pain-relieving endogenous opioids are released following surgical procedures and in patients given a placebo for pain relief. Pain-modulating circuits can enhance as well as suppress pain. Both pain-inhibiting and pain-facilitating neurons in the medulla project to and control spinal pain transmission neurons. Because pain transmission neurons can be activated by modulatory neurons, it is theoretically possible to generate a pain signal with no peripheral noxious stimuli. In fact, human functional imaging studies have demonstrated increased activity in this circuit during migraine headaches. A central circuit that facilitates pain could account for the finding that pain can be induced by suggestion or enhanced by expectation and provides a framework for understanding how psychological factors can contribute to pain. Neuropathic pain. Lesions in the peripheral or central nociceptor pathways typically result in loss or impairment of pain sensation. Paradoxically, damage to or dysfunction of these pathways can also produce pain. For example, damage to peripheral nerves, as occurs in diabetic neuropathy, or to primary afferents, as in herpes zoster infection, can result in pain that is referred to the body region innervated by the damaged nerves. Pain may also be produced by damage to the CNS, for example, in some patients following trauma or vascular injury to the spinal cord, brainstem, or thalamic areas that contain the central nociceptive pathways. Such pains are termed neuropathic and often severe and resistant to standard treatments for pain. Neuropathic pain typically has an unusual burning, tingling, or electric shock-like quality and may occur spontaneously without any stimulus or be triggered by very light touch. These features are rare in other types of pain. On examination, a sensory deficit is characteristically coextensive with the area of the patient's pain. Hyperpathia, a greatly exaggerated pain response to innocuous or mild nociceptive stimuli, especially when applied repeatedly, is also characteristic of neuropathic pain. Patients often complain that the very lightest moving stimulus evokes exquisite pain, allodynia. In this regard, it is of clinical interest that a topical preparation of 5% lidocaine in patch form is effective for patients with post-herpetic neuralgia who have prominent allodynia. A variety of mechanisms contribute to neuropathic pain. As with sensitized primary afferent nociceptors, damaged primary afferents, including nociceptors, become highly sensitive to mechanical stimulation and may generate impulses in the absence of stimulation. Increased sensitivity and spontaneous activity are due in part to an increased density of sodium channels in the damaged nerve fiber. Damaged primary afferents may also develop sensitivity to norepinephrine. Interestingly, spinal cord pain transmission neurons cut off from their normal input may also become spontaneously active. Thus, both central and peripheral nervous system hyperactivity contribute to neuropathic pain. Sympathetically maintained pain. Patients with peripheral nerve injury occasionally develop spontaneous pain in or beyond the region innervated by the nerve. This pain is often described as having a burning quality. The pain typically begins after a delay of hours to days or even weeks and is accompanied by swelling of the extremity, periarticular bone loss, and arthritic changes in the distal joints. Early in the course of the condition, the pain may be relieved by a local anesthetic block of the sympathetic innervation to the affected extremity. Damaged primary afferent nociceptors acquire adrenergic sensitivity and can be activated by stimulation of the sympathetic outflow. This constellation of spontaneous pain and signs of sympathetic dysfunction following injury has been termed complex regional pain syndrome, CRPS. When this occurs after an identifiable nerve injury, it is termed CRPS type 2, also known as post-traumatic neuralgia or if severe causalgia. When a similar clinical picture appears without obvious nerve injury, it is termed CRPS type 1, also known as reflex sympathetic dystrophy. CRPS can be produced by a variety of injuries including fracture of bone, soft tissue trauma, myocardial infarction, and stroke. CRPS type 1 typically resolves with symptomatic treatment. However, when it passes, detailed examination often reveals evidence of peripheral nerve injury. Although the pathophysiology of CRPS is poorly understood, the pain and the signs of inflammation when acute can be rapidly relieved by blocking the sympathetic nervous system. This implies that sympathetic activity can activate undamaged nociceptors when inflammation is present. Signs of sympathetic hyperactivity should be sought in patients with post-traumatic pain and inflammation and no other obvious explanation. Treatment: acute pain. The ideal treatment for any pain is to remove the cause. Thus, while treatment can be initiated immediately, efforts to establish the underlying etiology should always proceed as treatment begins. Sometimes, treating the underlying condition does not immediately relieve pain. Furthermore, some conditions are so painful that rapid and effective analgesia is essential. Example: the post-operative state, burns, trauma, cancer, or sickle cell crisis. Analgesic medications are a first line of treatment in these cases, and all practitioners should be familiar with their use. Aspirin, acetaminophen, and non-steroidal anti-inflammatory agents, NSAIDs. These drugs are considered together because they are used for similar problems and may have a similar mechanism of action. All these compounds inhibit cyclooxygenase, and except for acetaminophen, all have anti-inflammatory actions, especially at higher dosages. They are particularly effective for mild to moderate headache and for pain of musculoskeletal origin. Because they are effective for these common types of pain and are available without prescription, COX inhibitors are by far the most commonly used analgesics. They are absorbed well from the GI tract and with occasional use have only minimal side effects. With chronic use, gastric irritation is a common side effect of aspirin and NSAIDs and is the problem that most frequently limits the dose that can be given. Gastric irritation is more severe with aspirin, which may cause erosion and ulceration of the gastric mucosa, leading to bleeding or perforation. Because aspirin irreversibly acetylates platelet COX and thereby interferes with the coagulation of the blood, gastrointestinal bleeding is a particular risk. Older age and history of gastrointestinal disease increase the risk of aspirin and NSAIDs. In addition to the well-known gastrointestinal toxicity of NSAIDs, nephrotoxicity is a significant problem for patients using these drugs on a chronic basis. Patients at risk for renal insufficiency, particularly those with significant contraction of their intravascular volume, as occurs with chronic diuretic use or acute hypovolemia, should avoid NSAIDs. NSAIDs can also increase blood pressure in some individuals. Long-term treatment with NSAIDs requires regular blood pressure monitoring and treatment if necessary. Although toxic to the liver when taken in high doses, acetaminophen rarely produces gastric irritation and does not interfere with platelet function. The introduction of parenteral forms of NSAIDs, ketorolac and diclofenac, extends the usefulness of this class of compounds in the management of acute severe pain. Both agents are sufficiently potent and rapid in onset to supplant opioids as first-line treatment for many patients with acute severe headache and musculoskeletal pain. There are two major classes of COX. COX-1 is constitutively expressed and COX-2 is induced in the inflammatory state. COX-2 selective drugs have similar analgesic potency and produce less gastric irritation than the non-selective COX inhibitors. The use of COX-2 selective drugs does not appear to lower the risk of nephrotoxicity compared to non-selective NSAIDs. On the other hand, COX-2 selective drugs offer a significant benefit in the management of acute post-operative pain because they do not affect blood coagulation. Non-selective COX inhibitors, especially aspirin, are usually contraindicated post-operatively because they impair platelet-mediated blood clotting and are thus associated with increasing bleeding at the operative site. COX-2 inhibitors, including celecoxib, Celebrex, are associated with increased cardiovascular risk, including cardiovascular death, myocardial infarction, stroke, heart failure, or a thromboembolic event. It appears that this is a class effect of NSAIDs, excluding aspirin. These drugs are contraindicated in patients in the immediate period after coronary artery bypass surgery and should be used with caution in elderly patients and those with a history of or significant risk factors for cardiovascular disease. Opioid analgesics. Opioids are the most potent pain-relieving drugs currently available. Of all analgesics, they have the broadest range of efficacy and provide the most reliable and effective treatment for rapid pain relief. Although side effects are common, most are reversible. Nausea, vomiting, pruritus, sedation, and constipation are the most frequent and bothersome side effects. Respiratory depression is uncommon at standard analgesic doses, but can be life-threatening. Opioid-related side effects can be reversed rapidly with the narcotic antagonist naloxone. Many physicians, nurses, and patients have a certain trepidation about using opioids that is based on a fear of initiating addiction in their patients. In fact, there is a very small chance of patients becoming addicted to narcotics as a result of their appropriate medical use. For chronic pain, particularly chronic non-cancer pain, the risk of addiction in patients taking opioids on a chronic basis remains small. But the risk does not appear to increase with dose escalation. The physician should not hesitate to use opioid analgesics in patients with acute severe pain. Table 13.1 lists the most commonly used opioid analgesics. Codeine, oxycodone, oxycodone extended release, morphine, morphine sustained release, hydromorphone, levorphanol, methadone, meperidine, butorphanol, fentanyl, buprenorphine, tramadol. Opioids produce analgesia by actions in the CNS. They activate pain inhibitory neurons and directly inhibit pain transmission neurons. Most of the commercially available opioid analgesics act at the same opioid receptor, U receptor, differing mainly in the potency, speed of onset, duration of action, and optimal route of administration. Some side effects are due to accumulation of non-opioid metabolites that are unique to individual drugs. One of the striking examples of this is normeperidine, a metabolite of meperidine. At higher doses of meperidine, typically more than 1 gram per day, accumulation of normeperidine can produce hyperexcitability and seizures that are not reversible with naloxone. norepinephrine accumulation is increased in patients with renal failure. The most rapid pain relief is obtained by intravenous administration of opioids. Relief with oral administration is significantly slower. Because of the potential for respiratory depression, patients with any form of respiratory compromise must be kept under close observation following opioid administration. An oxygen saturation monitor may be useful, but only in a setting where the monitor is under constant surveillance. Opioid-induced respiratory depression is primarily manifest as a reduction in respiratory rate and is typically accompanied by sedation. A fall in oxygen saturation represents a critical level of respiratory depression and the need for immediate intervention to prevent life-threatening hypoxemia. Newer monitoring devices that incorporate capnography or pharyngeal airflow can detect apnea at the point of onset and should be used in hospitalized patients. Ventilatory assistance should be maintained until the opioid-induced respiratory depression has been resolved. The opioid antagonist naloxone should be readily available when opioids are used at high doses or in patients with compromised pulmonary function. Opioid effects are dose-related and there is great variability among patients in the doses that relieve pain and produce side effects. Synergistic respiratory depression is common when opioids are administered with other CNS depressants. Co-administration of benzodiazepines is particularly likely to produce respiratory depression and should be avoided, especially in outpatient pain management. Because of this variability in patient response, initiation of therapy requires titration to optimal dose and interval. The most important principle is to provide adequate pain relief. This requires determining whether the drug has adequately relieved the pain and timely reassessment to determine the optimal interval for dosing. The most common error made by physicians in managing severe pain with opioids is to prescribe an inadequate dose. Because many patients are reluctant to complain, this practice leads to needless suffering. In the absence of sedation at the expected time of peak effect, a physician should not hesitate to repeat the initial dose to achieve satisfactory pain relief. Now, standard approach to the problem of achieving adequate pain relief is the use of patient-controlled analgesia, PCA. PCA uses a microprocessor-controlled infusion device that can deliver a baseline continuous dose of an opioid drug as well as pre-programmed additional doses whenever the patient pushes a button. The patient can titrate the dose to the optimal level. This approach is used most extensively for the management of post-operative pain, but there is no reason why it should not be used for any hospitalized patient with persistent severe pain. PCA is also used for short-term home care of patients with intractable pain, such as that caused by metastatic cancer. It is important to understand that the PCA device delivers small, repeated doses to maintain pain relief. In patients with severe pain, the pain must first be brought under control with a loading dose before transitioning to the PCA device. The bolus dose of the drug, typically 1 mg of morphine, 0.2 mg of hydromorphone, or 10 mg of fentanyl, can then be delivered repeatedly as needed. To prevent overdosing, PCA devices are programmed with a lockout period after each demand dose is delivered, typically starting at 10 minutes, and a limit on the total dose delivered per hour. Although some have advocated the use of a simultaneous continuous or basal infusion of the PCA drug, this may increase the risk of respiratory depression and has not been shown to increase the overall efficacy of the technique. The availability of new routes of administration has extended the usefulness of opioid analgesics. Most important is the availability of spinal administration. Opioids can be infused through a spinal catheter placed either intrathecally or epidurally. By applying opioids directly to the spinal or epidural space adjacent to the spinal cord, regional anesthesia can be obtained using relatively low total doses. Indeed, the dose required to produce effective analgesia when using morphine intrathecally, 0.1 to 0.3 mg, is a fraction of that required to produce similar analgesia when administered intravenously, 5 to 10 mg. In this way, side effects such as sedation, nausea, and respiratory depression can be minimized. This approach has been extensively used during labor and delivery and for post-operative pain relief following surgical procedure. Continuous intrathecal delivery via implanted spinal drug delivery system is now commonly used, particularly for the treatment of cancer-related pain that would require sedating doses for adequate pain control if given systemically. Opioids can also be given intranasally, butorphanol, rectally and transdermally, fentanyl and buprenorphine, or through the oral mucosa, fentanyl, thus avoiding the discomfort of frequent injections in patients who cannot be given oral medication. The fentanyl and buprenorphine transdermal patches have the advantage of providing fairly steady plasma levels, which may improve patient comfort. Recent additions to the armamentarium for treating opioid-induced side effects are the peripherally acting opioid antagonists, alvimopin, Entereg, and methyl-naltrexone ranitidine. Alvimopin is available as an orally administered agent that is restricted to the intestinal lumen by limited absorption. Methyl-naltrexone is available in a subcutaneous administered form that is virtually no penetration into the CNS. Both agents act by binding to the peripheral mu receptors, thereby inhibiting or reversing the effects of opioids at these peripheral sites. The action of both agents is restricted to the receptor sites outside of the CNS. Thus, these drugs can reverse the adverse effects of opioid analgesics that are mediated through their peripheral receptors without reversing their CNS-mediated analgesic effects. Alvimopin has proven effective in lowering the duration of persistent EDS following abdominal surgery in patients receiving opioid analgesics for post-operative pain control. Methyl-naltrexone has proven effective for relief of opioid-induced constipation in patients taking opioid analgesics on a chronic basis. Opioid and COX inhibitor combination. When used in combination with opioids and COX inhibitors, have additive effects. Because a lower dose of each can be used to achieve the same degree of pain relief, and their side effects are non-additive, such combinations are used to lower the severity of those related side effects. However, fixed ratio combinations of an opioid with acetaminophen carry an important risk. Dose escalation as a result of increased severity of pain or decreased opioid effect as a result of tolerance may lead to an ingestion of levels of acetaminophen that are toxic to the liver. Although acetaminophen-related hepatotoxicity is uncommon, it remains a significant cause for liver failure. Thus, many practitioners have moved away from the use of opioid-acetaminophen combination analgesics to avoid the risk of excessive acetaminophen exposure as the dose of the analgesic is escalated. Chronic pain. Managing patients with chronic pain is intellectually and emotionally challenging. Sensitization of the nervous system can occur without any obvious precipitating cause, example, fibromyalgia or chronic headache. In many patients, chronic pain becomes a distinct disease unto itself. The pain-generating mechanism is often difficult or impossible to determine with certainty. Such patients are demanding of the physician's time and often appear emotionally distraught. The traditional medical approach of seeking an obscure organic pathology is often unhelpful. On the other hand, psychological evaluation and behaviorally based treatment paradigms are frequently helpful, particularly in the setting of a multidisciplinary pain management center. Unfortunately, this approach, while effective, remains largely underused in the current medical practice. There are several factors that can cause, perpetuate, or exacerbate chronic pain. First, of course, the patient may simply have a disease that is characteristically painful, for which there is no presently cure. Arthritis, cancer, chronic daily headaches, fibromyalgia, and diabetic neuropathy are examples of this. Second, there may be secondary perpetuating factors that are initiated by disease and persist after that disease is resolved. Examples include damaged sensory nerves, sympathetic efferent activity, and painful reflex muscle contractions, spasm. Finally, a variety of psychological conditions can exacerbate or even cause pain.
There are certain areas to which special attention should be paid in a patient's medical history because depression is the most common emotional disturbance in patients with chronic pain. Patients should be questioned about their mood, appetite, and sleep patterns and daily activity. A simple standardized questionnaire such as a Beck Depression Inventory can be a useful screening device. It is important to remember that major depression is a common, treatable, and potentially fatal illness. Other clues that a significant emotional disturbance is contributing to a patient's chronic pain complaint include pain that occurs in multiple unrelated sites, a pattern of recurrent but separate pain problems beginning in childhood or adolescence, pain beginning at a time of emotional trauma such as loss of a parent or spouse, a history of physical or sexual abuse, a past or present substance abuse. On examination, special attention should be paid to whether the patient guards the painful area and whether certain movements or postures are avoided because of pain. Discovering a mechanical component of the pain can be useful both diagnostically and therapeutically. Painful areas should be examined for deep tenderness, noting whether this is localized to muscle, ligament structures, or joints. Chronic myofascial pain is very common, and in these patients, deep palpation may reveal highly localized trigger points that are firm bands or knots in the muscle. Relief of the pain following injection of local anesthetic into these trigger points supports diagnosis. A neuropathic component of the pain is indicated by evidence of nerve damage, such as sensory impairment, explicitly sensitive skin, allodynia, weakness, and muscle atrophy, or loss of deep tendon reflexes. Evidence suggesting sympathetic nervous system involvement includes the presence of diffuse swelling, changes in skin color and temperature, and hypersensitive skin and joint tenderness compared with the normal side. Relief of the pain with a sympathetic block supports diagnosis. But once the condition becomes chronic, the response to sympathetic blockade is of variable magnitude and duration. The role of repeated sympathetic blocks in the overall management of CRPS is unclear. A guiding principle in evaluating patients with chronic pain is to assess both emotional and somatic causal and perpetuating factors before initiating therapy. Addressing these issues together rather than waiting to address emotional issues after somatic causes of pain have been ruled out improves compliance in part because it assures patients that a psychological evaluation does not mean that the physician is questioning the validity of their complaint. Even when a somatic cause for a patient's pain can be found, it is still wise to look for other factors. For example, a cancer patient with painful bony metastasis may have additional pain due to nerve damage and may also be depressed. Optimal therapy requires that each of these factors be assessed and treated. Treatment of chronic pain. Once the evaluation process has been completed and the likely causative and exacerbating factors identified, an explicit treatment plan should be developed. An important part of this process is to identify specific and realistic functional goals for therapy, such as getting a good night's sleep, being able to go shopping, or returning to work. A multidisciplinary approach that uses medications, counseling, physical therapy, nerve blocks, and even surgery may be required to improve the patient's quality of life. There are also some newer minimally invasive procedures that can be helpful for some patients with intractable pain. These include image-guided interventions, such as epidural injection of glucocorticoids for acute radicular pain and radiofrequency treatment of the facet joints for chronic facet-related back and neck pain. For patients with severe and persistent pain that is unresponsive to more conservative treatment, placement of electrodes on peripheral nerves or within the spinal canal, on nerve roots or in the space overlying the dorsal columns of the spinal cord stimulation, or implantation of intrathecal drug delivery systems has shown significant benefit. The criteria for predicting which patients will respond to these procedures continue to evolve. They are generally reserved for patients who have not responded to conventional pharmacological approaches. Referral to a multidisciplinary pain clinic for a full evaluation should precede any invasive procedure. Such referrals are clearly not necessary for all chronic pain patients. The sound pharmacologic management alone can provide adequate relief. Antidepressant medications. The tricyclic antidepressants, particularly nortriptyline and desipramine, table 13.1, are useful for the management of chronic pain. Table 13.1 antidepressants, doxepin, amitriptyline, imipramine, nortriptyline, desipramine, venlafaxine, duloxetine. Although developed for the treatment of depression, the tricyclic antidepressants have a spectrum of dose-related biologic activities that include analgesia in a variety of chronic clinical conditions. Although the mechanism is unknown, the analgesic effect of tricyclic antidepressants has a more rapid onset and occurs at a lower dose than is typically required for the treatment of depression. Furthermore, patients with chronic pain who are not depressed obtain pain relief with antidepressants. There is evidence that tricyclic antidepressants potentiate opioid analgesia, so they may be useful adjuncts for the treatment of severe persistent pain, such as occurs with malignant tumors. Table 13.2 lists some painful conditions that respond to tricyclic antidepressants. Table 13.2 Painful conditions that respond to tricyclic antidepressants: postherpetic neuralgia, diabetic neuropathy, fibromyalgia, tension headache, migraine headache, rheumatoid arthritis, chronic low back pain, cancer, and central post-stroke pain. Tricyclic antidepressants are of particular value in the management of neuropathic pain, such as occurs in diabetic neuropathy and postherpetic neuralgia, for which there are few other therapeutic options. The tricyclic antidepressants that have been shown to relieve pain have significant side effects. Some of these side effects, such as orthostatic hypotension, drowsiness, cardiac conduction delay, memory impairment, constipation, and urinary retention, are particularly problematic in elderly patients, and several are additive to the side effects of opioid analgesics. The selective serotonin reuptake inhibitors, such as fluoxetine, Prozac, have fewer and lesser serious side effects than tricyclic antidepressants, but they are much less effective for relieving pain. It is of interest that venlafaxine, Effexor, and duloxetine, Cymbalta, which are non-tricyclic antidepressants that block both serotonin and norepinephrine reuptake, appear to retain most of the pain-relieving effect of tricyclic antidepressants, with the side effect profile more like that of selective serotonin reuptake inhibitors. These drugs may be particularly useful in patients who cannot tolerate the side effects of tricyclic antidepressants. Convulsants and antiarrhythmics. These drugs are useful primarily for patients with neuropathic pain. Phenytoin, dilantin, and carbamazepine, Tegretol, were first shown to relieve the pain of trigeminal neuralgia. This pain has a characteristic brief, shooting, electric shock-like quality. In fact, anticonvulsants seem to be particularly helpful for pains that have such a lancinating quality. Newer anticonvulsants, the calcium channel alpha-2 delta subunit ligands gabapentin, neurontin, and pregabalin, Lyrica, are effective for a broad range of neuropathic pains. Furthermore, because of their favorable side effect profile, these new anticonvulsants are often used as first-line agents. Cannabinoids. These agents are widely used for their analgesic properties. Although published evidence suggests that any effects are likely to be modest, with small increases in pain threshold reported and variable reductions in clinical pain intensity. Cannabis more consistently reduces the unpleasantness of the pain experience, and in cancer-related pain can lessen the nausea and vomiting associated with chemotherapy use. Marijuana and related compounds are discussed in chapter 455. Chronic opioid medication. Long-term use of opioids is accepted for patients with pain due to malignant disease. Although opioid use for chronic pain of non-malignant origin is controversial, it is clear that for many patients, opioids are the only option that produces meaningful pain relief. This is understandable because opioids are the most potent and have the broadest range of efficacy of any analgesic medications. Although addiction is rare in patients whose first use of opioids for pain relief, some degree of tolerance and physical dependence is likely with long-term use. Furthermore, studies suggest that long-term opioid therapy may worsen pain in some individuals, termed opioid-induced hyperalgesia. Therefore, before embarking on opioid therapy, other options should be explored, and the limitations and risks of opioids should be explained to the patient. It is also important to point out that some opioid analgesic medications have mixed agonist-antagonist properties, example butorphanol and buprenorphine. From a practical standpoint, this means that they may worsen pain by inducing an abstinence syndrome in patients who are actively being treated with other opioids and are physically dependent. With long-term outpatient use of orally administered opioids, it may be desirable to use long-acting compounds such as levorphanol, methadone, extended-release morphine, or oxycodone, or transdermal fentanyl. The pharmacokinetic profiles of these drug preparations enable the maintenance of sustained analgesic blood levels, potentially minimizing side effects such as sedation that are associated with high peak plasma levels and reducing the likelihood of rebound pain associated with a rapid fall in plasma opioid concentration. Extended-release opioid formulations are approved primarily for patients who are already taking other opioids and should not be used as first-line opioids for pain. Although long-acting opioid preparations may provide superior pain relief in patients with a continuous pattern of ongoing pain, others suffer from intermittent severe episodic pain and experience superior pain control and fewer side effects with the periodic use of short-acting opioid analgesics. Constipation is a virtually universal side effect of opioid use and should be treated expectantly. As noted earlier in the discussion of acute pain treatment, a recent advance for patients is the development of peripherally acting opioid antagonists that can reverse the constipation associated with opioid use without interfering with analgesia. Soon after the introduction of an extended-release oxycodone formulation, OxyContin, in the later 1990s, a dramatic rise in the emergency department visits and deaths associated with oxycodone ingestion appeared. This appears to be primarily due to the individuals using a prescription opioid non-medically. Drug-induced deaths have rapidly risen and are now the second leading cause of death in Americans, just behind motor vehicle fatalities. In 2011, the Office of National Drug Control Policy established a multifaceted approach to address prescription drug abuse, including prescription drug monitoring programs, PDMPs, that allow practitioners to determine if patients are receiving prescriptions from multiple providers and use of law enforcement to eliminate improper prescribing practices. In 2016, the Centers for Disease Control and Prevention, CDC, released the CDC guideline for prescribing opioids for chronic pain, with recommendations for primary care clinicians who are prescribing opioids for chronic non-cancer pain. A modified approach to opioid prescribing was published in 2019 by the Health and Human Services Task Force on Chronic Pain Best Medical Practices. These guidelines address when to initiate or continue opioids for chronic pain, opioid selection, dosage, duration, follow-up, and discontinuation, assessing risk and addressing harms of opioid use. The recent increase in scrutiny leaves many practitioners hesitant to prescribe opioid analgesics other than for brief periods to control pain associated with illness or injury. For now, the choice to begin chronic opioid therapy for a given patient is left to the individual practitioner. Pragmatic guidelines for proper selecting and monitoring patients receiving chronic opioid therapy are shown in Table 13.3. A checklist for primary care clinicians prescribing opioids for non-cancer pain is shown in Table 13.4. Table 13.3 Guidelines for selecting and monitoring patients receiving chronic opioid therapy for the treatment of chronic non-cancer pain. Patient selection. Conduct a history, physical examination, and appropriate testing, including an assessment of risk of substance abuse, misuse, or addiction. Consider trial of chronic opioid therapy if pain is moderate or severe, pain is having an adverse impact on function or quality of life, and potential therapeutic benefits outweigh potential harms. A benefit to harm evaluation, including a history, physical examination, and appropriate diagnostic testing, should be performed and documented before an ongoing basis during chronic opioid therapy. Informed consent and use of management plans. Informed consent should be obtained. A continuing discussion with the patient regarding chronic opioid therapy should include goals, expectations, potential risks, and alternatives to COT. Consider using a written COT management plan to document patient and clinician responsibilities and expectations and assist in patient education. Initiation and titration. Initial treatment with opioids should be considered as a therapeutic trial to determine where COT is appropriate. Opioid selection, initial dosing, and titration should be individualized according to the patient's health status, previous exposure to opioids, attainment of therapeutic goals, and predicted or observed harms. Monitoring. Reassess patients on chronic opioid therapy COT periodically and as warranted by changing circumstances. Monitoring should include documentation of pain intensity and level of functioning, assessments of progress towards achieving therapeutic goals, presence of adverse events, and adherence to prescribed therapies. In patients on COT who are at high risk or who have been engaged in aberrant drug-related behaviors, clinicians should periodically obtain urine drug screens or other information to confirm adherence to the COT plan of care. In patients on COT not at high risk and not known to have engaged in aberrant drug-related behaviors, clinicians should have considered periodically obtaining urine drug screens or other information to confirm adherence to the COT plan of care. Table 13.4 Centers for Disease Control and Prevention Checklist for prescribing opioids for chronic pain. For primary care providers treating adults 18 plus with chronic pain more than equal to 3 months, excluding cancer, palliative, and end-of-life care. Checklist. When considering long-term opioid therapy, set realistic goals for pain and function based on diagnosis. Example, walk around the block. Check that non-opioid therapy is tried and optimized. Discuss benefits and risks. Example, addiction, overdose with the patient. Evaluate risk of harm or misuse. Discuss risk factors with the patient. Check prescription drug monitoring program PDMP data. Check urine drug screen. Set criteria for stopping or continuing opioids. Assess baseline pain and function. Example, pain, enjoyment, general activity, PEC scale. Schedule initial reassessment within 1 to 4 weeks. Prescribe short-acting opioids using lowest dosage on product labeling. Match duration to schedule reassessment. If renewing without a patient visit, check that return visit is scheduled less than equal to 3 months from last visit. When reassessing at a patient visit, continue opioids only after confirming clinically meaningful improvements in pain and function without significant risks or harm. Assess pain and function. Example, PEG. Compare results to baseline. Evaluate risk of harm or misuse. Observe patient for signs of oversedation or overdose risk. If yes, taper dose. Check PDMP. Check for opioid use disorder if indicated. Example, difficulty controlling use. If yes, refer for treatment. Check that non-opioid therapies are optimized. Determine whether to continue, adjust, taper, or stop opioids. Calculate opioid dosage morphine milligram equivalent MME. If more than equal to 50 MME per day total, more than equal to 50 mg hydrocodone, more than equal to 33 mg oxycodone, increase the frequency of follow-up, consider offering naloxone. Avoid more than equal to 19 morphine milligram equivalent per day total, more than equal to 90 mg hydrocodone, more than equal to 60 mg oxycodone, or carefully justify, consider specialist referral. Schedule reassessment at regular intervals less than equal to 3 months. Treatment of neuropathic pain. It is important to individualize treatment for patients with neuropathic pain. Several general principles should guide therapy. The first is to move quickly to provide relief, and the second is to minimize drug side effects. For example, in patients with post-herpetic neuralgia and significant cutaneous hypersensitivity, topical lidocaine, lidoderm patches, can provide immediate relief without side effects. The anticonvulsants, gabapentin or pregabalin, or antidepressants, nortriptyline, desipramine, duloxetine, or venlafaxine, can be used as first-line drugs for patients with neuropathic pain. Systemically administered antiarrhythmic drugs, such as lidocaine and mexiletine, are less likely to be effective. Although intravenous infusion of lidocaine can provide analgesia for patients with different types of neuropathic pain, The relief is usually transient, typically lasting just hours after the cessation of the infusion. The oral lidocaine congener, mexiletin, is poorly tolerated, producing frequent gastrointestinal adverse effects. There is no consensus of which class of drug should be used as a first-line treatment for any chronically painful condition. However, because relatively high doses of anticonvulsants are required for pain relief, sedation is not uncommon. Sedation is also a problem with tricyclic antidepressants, but is much less of a problem with serotonin or norepinephrine reuptake inhibitors, SNRIs, example venlafaxine and duloxetine. Thus, in the elderly or in patients whose daily activities require high-level mental activity, these drugs should be considered the first line. In contrast, opioid medications should be used as a second or third line drug class. Although highly effective for many painful conditions, opioids are sedating and their effect tends to lessen over time, leading to dose escalation and occasionally a worsening of pain. A couple of interesting alternatives to pure opioids are two drugs with mixed opioid and norepinephrine reuptake action, which is tramadol and tapentadol. Tramadol is a relatively weak opioid but is sometimes effective for pain unresponsive to non-opioid analgesics. Tapentadol is a stronger opioid, but its analgesic action is apparently enhanced by a norepinephrine reuptake blockade. Similarly, drugs of different classes can be used in combination to optimize pain control. Repeated injection of botulinum toxin is an emerging approach that is showing some promise in treating focal neuropathic pain, particularly post-herpetic, trigeminal, and post-traumatic neuralgias. It is worth emphasizing that many patients, especially those with chronic pain, seek medical attention primarily because they are suffering and because only physicians can provide the medications required for pain relief. A primary responsibility of all physicians is to minimize the physical and emotional discomfort of the patients. Familiarity with pain mechanisms and analgesic medications is an important step towards accomplishing this aim. Thank you.